Ladies and gentlemen, dear colleagues, first of all, I would like to express my thanks to organizers of this meeting. It's my pleasure to be here. Unfortunately, I'm not here in reality. However, we tried to do our best, and I will share our experiences with familial hypercholesterolemia with you from this video. This is my disclosure slide. What are we going to talk about? We will start with history, then I'll share with you with experiences of 50 years of familial hypercholesterolemia in our Center of Preventive Cardiology, and then we will conclude. I'll start with his story. This guy is my teacher, Professor Šobra, who started his lipid clinic in Prague in 1959, and it was in the same year as Dick Havel did in San Francisco. In 1972, Šobra developed lipid national conferences, and he established the network of lipid clinics in former Czechoslovakia. In 1971, he wrote the first book concerning familial hypercholesterolemia, and then he started many educational activities. On this slide, we can see the first monograph about familial hypercholesterolemia, which was written by Šobra, and some pictures from this book. Šobra always stressed and underlined family history, and this is really necessary to say that family history is very important, and I would like to demonstrate it on two slides. This is a very old slide from 1963, and we can see proband who was 42 years old, and he suffered myocardial infarction, and his total cholesterol was very, very high. It was almost 13 millimoles per liter, and nothing serious was in the family. And this is another slide from this family, but this is a slide from 1976, and we can see that our patient died when he was 50 because of myocardial infarction, and also his brother died when he was 44, and the third brother had a myocardial infarction when he was 48. Also, mother of our patient died because of myocardial infarction, and even his daughter, and she was only 32, suffered myocardial infarction, and in the family we can demonstrate very high levels of total and LDL cholesterol, as you can see on this slide. Some clinical picture, some clinical signs of familial hypercholesterolemia: arcus lipoides, xanthelasma palpebrarum, xanthomas, tendon xanthomas, Achilles tendons, and again manifestation of familial hypercholesterolemia in a young lady with arcus lipoides. Unfortunately, this lady died when she was 34 despite complex therapy. And on this slide we can demonstrate again xanthomas, xanthelasma and arcus lipoides in our patient with familial hypercholesterolemia. Also on this slide you can see xanthelasma and again xanthomas, Achilles tendons. And this historical building is building where our Center of Preventive Cardiology is located, and I would like to demonstrate changes between 1960 and 2016, when we compared the original group of patients of Professor Shobra, they were about 200, and now we have more than 800 patients, and we can demonstrate a relatively higher level of total cholesterol, which is now 9.7, LDL cholesterol 7.2. And what is quite interesting is the difference in TG levels. TGs went up from a very normal level 1.17 to recent levels 1. Almost 8. Xanthomatosis is not very frequent at all. However, it was much more frequent in old times of Professor Shobra. Now we can find xanthomas only in 3% of our patients. We can analyze our group of patients, as I told you already, more than 800. The majority of them are adults, but we take care also of children. And coronary heart disease in our group of patients is very frequent. 1/3, children included, are patients coronary heart disease positive, and in 15% we can describe a very early manifestation of coronary heart disease in men less than 45, and in women less than 55. What is quite important, usually people think that people with elevated cholesterol are obese, but this is not true, at least for patients with familial hypercholesterolemia. Only 10% or 12.5% of our patients are obese. Diabetes, again, is not connected with familial hypercholesterolemia. Hypertension incidency corresponds quite well to a general population, and as I already mentioned, xanthomatosis is decreasing. Again, we can look at lipid levels. Total cholesterol in our group of patients 9.7. In patients with LDL receptor mutation, LDL cholesterol is 7.7. Total cholesterol more than 10. In FDB patients, levels are relatively better and lower. Severe familial hypercholesterolemia in our group is described on this slide, and we can demonstrate that 1/3 of our patients have total cholesterol above 10 millimole per liter, and 1% above 15 millimoles per liter. And if we look at LDL cholesterol, still 10 millimole per liter for LDL cholesterol have almost 7% of our patients. This is quite important slide describing treatment of familial hypercholesterolemia in our patients. Target levels we reached in almost 40% of our patients, and another target for the successful treatment of familial hypercholesterolemia is a decrease of LDL cholesterol by 50%, and 70% of our patients have this decrease of LDL by 50 or more percent of LDL cholesterol. Unfortunately, I have to say that we used in this relatively long period of follow-up of our patients, we used 25 different treatment regimens. But the most important and most frequently used regimen is rosuvastatin 40 milligrams in combination with ezetimibe, and ezetimibe we use also with high dose of atorvastatin 80 milligrams, and also we use triple therapy rosuvastatin, ezetimibe and fenofibrate. I think that this is necessary to underline the necessity of combination therapy, and as you had possibility to see on the last slide, the best combination for patients with familial hypercholesterolemia is combination statin plus ezetimibe, and why treatment is very effective. This is safe, well tolerated, and this is evidence-based, and it was a problem of ezetimibe for many years that we didn't have sufficient data concerning reduction of cardiovascular morbidity and mortality. However, now the situation is much better for us after presentation in Chicago, and after publication we can use data from IMPROVE-IT trial, and IMPROVE-IT trial demonstrates clearly additional decrease of LDL cholesterol after ezetimibe simvastatin treatment, and this decrease is accompanied with a statistically significant reduction of cardiovascular events. This is also important to mention that on-treatment analysis of IMPROVE-IT trial can demonstrate even better result for combo therapy ezetimibe statin in comparison with statin monotherapy. In the future, we are expecting big changes because a new group of lipid-lowering drugs is coming, and these are PCSK9 inhibitors, and we have experiences in our Center of Preventive Cardiology in almost 300 patients. We are National Center of MedPath Project in the Czech Republic, and the Czech Republic has almost 90 centers, quite well dispersed in the country, and we are quite successful even in detection of familial hypercholesterolemia, and we are occupying third place in the world. The first is Netherlands. There is no comparison with them because of their state support, then Norway, and then Czech Republic. And because we have quite good experiences in our country, we are now trying to develop international project, ScreenPro FH Project, which covers countries from Central, Eastern and Southern Europe. You can see the list of these countries from Czech Republic to Turkey, Greece, Russia, Ukraine, and even countries like Kyrgyzstan and Uzbekistan are participating in this project. And at the end of my presentation, I would like to demonstrate that this project is really really big, and we take care of almost 500 million of people, and if we translate this number to FH population, in this country live 1-2 million of FH heterozygotes, and we should improve the care of these patients. Thank you very much.